Hello, everybody. Today we're going to do a little bit of airway management, a little bit of pathophys, and some anatomy and whatnot. We'll start off with some anatomy. So it's divided up into two sections. You've got your lower and your upper airways. Right. So your upper airway would be your nasopharynx, your nasal passages, your mouth, your teeth, your tongue, oropharynx going down to your epiglottis, which is that leaf-shaped thing that separates trachea from esophagus, right? Your larynx, and we get down to your lower airway. Starting at your trachea, goes down, bifurcates at the carina into your two main stem bronchi, into bronchioles, smaller and smaller, right? All the way down into your lungs, your alveoli. You've got your pulmonary capillaries. This is where we have exchange for oxygen and carbon dioxide. You also have in here, you have your diaphragm, which is responsible for a lot of your actual ventilation, your moving of air in and out. Your left lung, you've got 2 lobes, and your right lung, you have 3. They say that's just because of how the heart's positioned in there, more towards the left side. Most people have a little flap on their left lung that is believed to actually be what used to be a third lobe, but there's no way of really proving it. So that's the basic airway anatomy. Your upper airway is made for purifying, keeping dust out, things like that, humidifying, and then your lower airway is primarily for the actual exchange and the mechanical aspect of it when it comes to bringing air in and out, exchanging oxygen for carbon dioxide, all that different fun stuff. We'll use our diaphragm and our intercostals, the muscles in between our ribs, when it comes to inhaling and exhaling. You can get your bronchi can become inflamed with like asthma, COPD, things like that, and those get smaller, preventing airflow. You can have damage into your alveoli. You can have fluid buildup in there with pulmonary edema. You have COPD, which is air trapping. We'll get a buildup of air in these, which then prevents oxygenation from happening and things like that. So many different things could go wrong with this in all aspects. Upper airway swelling with anaphylaxis and allergic reactions, swelling of the tongue, swelling of deviated septum in the nasal passages. Many things can make this whole system kind of go awry. In here, you also have what we call the mediastinum. This is everything that is centered, kind of under your sternum. This would be your heart, all your great vessels, your vena cava. You've got your inferior and superior vena cavas, your aorta, your aortic arch, your descending aorta, the 3 branches that go to the arms and the head. Notice the lungs are kind of in here, but they kind of are also on the outlying borders of your mediastinum. But you also have your trachea, and where your main bronchi are, and then part of your diaphragm as well. If we have damage or trauma to that mediastinum, there's a lot of things in that area that have major roles to play in maintaining life and oxygenation and blood flow and circulatory. So when that gets compromised, we have a very high index of suspicion that this is going to be a very critical patient for us. Okay. So moving on from anatomy, we have a little bit of physiology, right? We have 3 key things here. We've got ventilation, oxygenation, and respiration. Ventilation is just the physical act of moving air in and out. It's something that we do naturally ourselves, but it's also something that us as an EMS provider can manually do. So we can manually ventilate somebody, taking over that airway, which is one of the reasons why I love airways so much, is because it's the one thing that we can actually control, and we can maintain and elongate life and even keep the heart alive with the body not doing this by itself, right? And we can do it almost indefinitely if we catch it fast enough, do it adequately enough. We got people on long-term ventilators in hospitals for months, and they do okay. Well, you know, just kind of, I guess you could say. They don't die. But something what's kind of interesting is the heart and the lungs. The circulatory system, I should say, and the respiratory system have a suicide pact, in the matter of speaking, where if one of them fails, the other one will fail shortly after that, right? So if the lungs fail, then the heart's going to fail soon after. But we can control the respiratory aspect of it. So we can actually trick the heart into thinking the lungs are still going, and we can actually preserve the heart, It's not something that really goes the other way around. If the heart fails, it's hard for us to maintain that well enough that the lungs go, oh, I'm doing okay. Hence, like CPR and all that stuff, right? So that's ventilation. Oxygenation is just the simple act of loading oxygen onto molecules, onto hemoglobin. So this is just oxygen molecules being loaded onto hemoglobin. That's all it is. This can be affected by amount of oxygen in the atmosphere, oxygen-deprived environments, things like that. This will be compromised. But it's just that simple: oxygen molecules being loaded onto hemoglobin for oxygenation. And respiration. Respiration is the exchange of oxygen for carbon dioxide. This is both an internal and external process, both of which happen inside the body. And we'll talk about this here in a minute, but essentially it's just that process of loading oxygen onto stuff and picking up carbon dioxide. It's like the UTA bus system, right? In a way. Ventilation. So as the diaphragm contracts over here, it moves down, right? That moves down, intercostals activate, and it causes a negative pressure within our thoracic cavity, which is, our thoracic cage, ribs, diaphragm. This is all the thoracic cavity. So with that negative pressure, fills the lungs with air. Okay, that is an active process. It takes muscles to do that. And then everything relaxes. Goes back to where it normally is. That negative pressure goes away, and we exhale. Now, this is normally a passive process, but this can be a active process as well. We can forcefully exhale if we want. But with that being said, normally when we exhale, we have a residual amount of oxygen or air in our lungs between 250 to 500 milliliters of air in our lungs, which is also why when people do compression-only CPR, they're actually able to circulate that remaining volume of air, and there is some oxygen in that, which allows us to just kind of put off airway for a little bit as a layperson. Like I said, for you guys, will be the same, 30 to 2, all that fun stuff. But that's the ventilation process of how we draw in air. And we'll go into a little bit more later on with actual manual ventilation and all of that. Oxygenation, talked about it already. There's not much more to discuss on it. Process of loading oxygen molecules onto hemoglobin in the bloodstream. Excuse me. Respiration. Okay, so we've got external and we've got internal. Like I said, both of these happen within inside the body though. External is here. It happens within the lungs, out the alveoli, where O2 goes into the capillary beds and CO2 goes out of them back into the lungs to be exhaled. Alright, so you've got all three alveoli, your pulmonary, capillaries, and arterioles. Right? So what happens here is essentially this, in essence, just on the alveoli, where we breathe O2 in, or air in, that's oxygen rich. That then goes into the bloodstream, the CO2 comes out, we breathe off the CO2, breathe on more O2, goes in, comes out, breathe out. And it's just that process over and over and over again. That is external respiration. Internal is just the process of oxygen and nutrients going into cells and tissues, and carbon dioxide and byproduct going into the bloodstream to then come back over here, get offloaded. We exhale it out, we inhale more oxygen, and it's just a continuous process, right? This happens throughout the entire body at all cells and tissue levels. This is perfusion in essence. Right? And we have a bunch of, like, throughout the body of chemoreceptors that monitor these oxygen levels, along with hydrogen levels, pH balances, and things like that, that will monitor and dictate how fast we're breathing and how fast our heart is beating in order to maintain this. So when this gets scawampus and our pH balance is thrown off and it's no longer in that 7.35, 7.45 range that it likes to be in, then respirations will change to counteract that. For instance, we'll talk about diabetic ketoacidosis, and along with that comes Kussmaul respirations, which is the body's way of trying to breathe off an acid base because of the differential in pH levels, and it's trying to get rid of more byproduct.